Hello, I'm Dr. BVG, and this is my brief introduction. I would like to talk on IV contrast used in CT scan and MRI. I'm not going to bore you on molecular structures of contrast or on how contrast applies to CT scan and MRI. I just want to discuss some practical aspects that we face in our day-to-day work. But before I begin about IV contrast in CT scan, there are two terms that should be very familiar to us. One is the low osmolality, where osmolality is twice that of human serum, which is iohexol and iopamidol. And isoosmolality, where osmolality is equal to that of the serum, that is iodixinol. Now, please understand that low osmolality means that osmolality may be 2 or 3 times that of human serum. And it does not mean that it is lower than human serum. This is a mistake which we often make in our understanding of low osmolar contrast. Also, I have disregarded and not used the term high osmolar contrast media. They are no longer in use, they should never be in use. And they have been largely replaced by low osmolar and isoosmolar contrast media. So what are the considerations that we have? The considerations are, what is the benefit of using a contrast media versus the risk of contrast media use, and what are the imaging alternatives available? The benefit first. So whenever people talk on the benefit of using an IV contrast media in CT, they always tell us, look, if you fail to diagnose an important clinical entity while only doing a plain CT scan, then it's going to be very risky or troublesome to the patient. This sounds very good in theory, but this is lots of bullshit. First, understand that contrast is a drug, and this drug is used for diagnosis. This is not a drug like a hypertensive or anti-diabetic medication which is used for therapy. And always there is a safer path available. So in case you strongly suspect a clinical entity and you get a normal result on the CT scan, then it doesn't mean that you end up giving contrast irrespective of the risk involved, because there is always another alternative existing. Now, firstly, whenever we talk about IV contrast in CT scan, you talk about the word reaction. Now, reaction is a word which is very loosely used for any kind of adverse event. An adverse event in case of presently used IV contrast media are historical. Meaning, all these adverse events which have been described in the book are all for the old, no longer used high osmolar contrast media. As we will see during the course of this talk, that the low osmolar contrast media and the isoosmolar contrast media are generally safe. Need not be afraid of them anymore. But then what are the adverse effects? So there are 3 of them which are very commonly seen: extravasation, the allergic reaction, and CIN, which is contrast induced nephropathy. But there is a far more important adverse event which we are never discussing. This is the pyrogenic reaction. Now, what is this pyrogenic reaction that we are talking about? This is caused by an infusion of contrast which has been contaminated, and it is commonly manifested by cold, chill, and fever. So after you have given a contaminated IV contrast, then the patient post-contrast develops cold, chill, and fever. And this is the pyrogenic reaction in the context of IV contrast media. And the most important cause for this is multi-dosing from a pharmacy bulk packaging. Now, what is pharmacy bulk packages are? See, when you buy contrast media, you can buy a 10 ml one, 20 ml one, 50 ml one, or you can buy a 5-liter pack. Now, when you buy a 5-liter pack or a 1-liter pack, you end up giving this contrast to multiple patients over a certain period of time. But this pharmacy bulk packaging of 5-liter may not be suitable for multi-dosing. So when you open it, you might end up contaminating it. It might not have any preservative, and this is one of the most common causes for pyrogenic reactions. So here, the solution is single dose only. When you open a bottle of contrast media, you use it only for a single patient. And then whatever is left, maybe 5 ml, 10 ml, whatever, you throw in the dustbin. It's small this thing because contrast media in the third world country is going to be little costly for the patient. And then we are always looking forward to saving some money. I don't mind the use of this contrast media which is left over as oral contrast. So you can use this contrast media as oral contrast, and that also within the same day. It should not be used for the next day. Then we come to another adverse event associated with IV contrast media. This is the contrast-induced acute kidney injury. There is another term which I have put next to it, which is the contrast-associated acute kidney injury. So what is a contrast-associated acute kidney injury? Meaning, see, the patient has a poor renal outcome in a period which is just after you have given contrast. The contrast itself may not be a sole responsible entity for acute kidney injury. That is why we would prefer to use the word contrast associated acute kidney injury till the time it becomes very clear that the contrast which we have given is the primary reason for acute kidney injury. The most common question that everybody will ask us is, do I do serum creatinine as a baseline for all patients who are going to undergo a contrast CT study? Now, no need. No need to do serum creatinine in all the patients. You should do it whenever the age of the patient is more than 60 years, wherever there is a history of renal disease, hypertension, and diabetes. Now, the current literature talks about EGFR, and they say that EGFR is going to be a more accurate value than serum creatinine baseline. Now, this I found is splitting hairs. We are already moving towards safer and safer IV contrast media. Used properly, I think the only thing to be done is serum creatinine baseline in the potential risky cases. So here we have some definitions where you will say the patient has got a contrast-induced nephropathy, where there is an absolute increase in serum creatinine or a percentage increase in serum creatinine or a urine output which has reduced. The values are given in the slide for your reference. So who has a risk of contrast-induced nephropathy? People with renal problems, pre-existing diabetes, patients on nephrotoxic drugs, dehydrated patients, patients with congestive heart failure and multiple myeloma. But then one of the most important risk as far as a radiology center is concerned is a recent contrast injection of more than 100 to 120 ml in the preceding 24 hours. Now, I'll tell you why this is a very, very important factor. Sometimes a patient gets referred to us for a contrast CT scan of the chest. We might give him some 80 or 100 ml of contrast. Thereafter, he goes back to his doctor or the ward, and then in the evening round, the referring physician says, do a CT scan of the abdomen also. So patient gets referred to us for a CT abdomen with contrast, and you end up giving 100 and 120 ml of contrast more. Now this is going to be a very risky situation. So I would strongly recommend that in case a patient has undergone a contrast CT study, wait for a day. Wait for a day and then you can give more contrast and do a contrast study of a different part. This is because contrast-induced nephropathy is a dose-toxicity relationship, and it is very, very uncommon with volumes of 100 ml or less. So if you are going to give IV contrast less than 100 ml, you need not fear contrast-induced nephropathy. Now, obviously, we are talking about low osmolar contrast media and the isoosmolar contrast media. And this is why you should always wait a day between two contrast CT studies. What about prior fasting? Should you keep the patient fasting for 4 to 6 hours before the contrast study? It is very common for the departments, big hospitals, even diagnostic centers to keep the patient NBM for 4 to 6 hours. Except I have found prior fasting is associated with scheduling limitations. For example, patient may have come from outside. He may have come from a far off places 200, 600 kilometers away. And then I have to tell him, look, we can't do it today. You have to come tomorrow with 6 hours of fasting. Now he is going to have to spend an entire day wasted just because we are keeping him nil by mouth. But most importantly, it creates hypoglycemia, obviously, and a general discomfort. Also, why do you keep the patient fasting? We kept the patient fasting in the earlier days because high osmolar contrast media frequently produced vomiting. And then we thought the patient might aspirate, end up in an ICU, so we kept the patient fasting. But here, surprise, surprise, in a 2012 study, there is no cases of aspiration pneumonia seen. Also, there is an important role of hydration, as I have talked in the previous slide, in preventing contrast-induced nephropathy. So if you are keeping the patient fasting for 4 to 6 hours, means you are making him dehydrated and there is a potential risk for contrast-induced nephropathy. You're causing the patient more harm by keeping him fasting. I give a big thumbs down to prior fasting. Now there is another adverse event, which is the extravasation. Extravasation means that instead of giving the drug IV, you have put the drug somewhere in the subcutaneous tissues. This is very common. This is not as uncommon as we thought it was. And this is how extravasation would look like. You see there is swelling, redness over the injection site. The factors which affect extravasation of contrast are the volume. If you're going to give a larger volume of contrast, the more risk that there is extravasation. Then, if you're giving a hand bolus versus power injectors. And then finally, the osmolality of the contrast. Here I have not written another term which I should have is the viscosity. Most important thing to remember whenever there is an extravasation is all treatments given in a diagnostic center are generally ineffective. So don't poke the affected area with a needle. There is no need to do some limb elevation, hot and cold compress and drugs. A big thumbs down, not required, totally ineffective. So what do? Most often, the extravasation will subside by itself, will not produce any sort of an adverse event. But then you keep on watching for severe pain, for swelling, for change in sensation, for worsening range of motion, and skill ulceration or blistering. Now, if these things happen after extravasation of IV contrast, then you have to better refer him to a surgical department to manage it. What do you do with reducing the risk of extravasation? How do you give IV contrast so that there is very little risk of extravasation? Obviously, whenever you're putting an intravenous line, you do it meticulously. You use the right antecubital vein, use a 20G caliber, and you use an angiocatheter instead of a butterfly catheter. Then you confirm the position by aspirating blood, giving a small test injection of saline and seeing that there is no extravasation with saline, and then putting some sticking tape over the angiocath so that it is carefully and properly secured. The most problematic event of extravasation is whenever you are giving it by a pressure injector. Now, in a hand injection, if you are giving a bolus of IV contrast and you see extravasation, what you do is generally stop and then you try to give the contrast at some other site. But with a pressure injector, usually what happens is you start the pressure injector remotely, and if extravasation has occurred, then you are unable to stop it in time. So here my suggestion is, if you are giving contrast injection by pressure injector, you wait for the first 15 seconds next to the patient to see whether there is an extravasation or not. If there is no extravasation, then you leave after 15 seconds. In any case, your scanning will start about 15 seconds after you have started the injection. So you are no longer in a radiation zone after that. You leave the room after 15 seconds. Now, in the interim, in the first 15 seconds, if you encounter extravasation, you stop the injection, obviously. Now, there was an ACR project which came out with a very surprising finding. They say, whatever you do, you may not achieve significant improvement. And then somebody suggested that why don't you pre-warm the low osmolar contrast media to reduce the viscosity. Remember, lower viscosity will lead to lesser chances of an extravasation. Sorry, but I have never tried it, extensive warming. not required for our kind of a country. Also, it is not very useful in hand injections. Now let us discuss another adverse event, the allergic, which is dose dependent, a rash type of reaction, and a physiological, which is seizures or something very similar, which depends on the dose. And the third is the vasovagal. Now, serious acute reactions which are allergic in nature are very, very uncommon. How uncommon? 0.04%. When I talk about serious acute reactions, I'm talking about those serious acute reactions which will end up with the patient in a critical care ward of a hospital. So they are very, very uncommon. Okay, you might get an occasional allergic reaction even with low osmolar contrast media or with isoosmolar contrast media, but they are not going to be life-threatening to the patient. Also, even when serious acute reactions might occur, the chance of a mortality is 0. But if you have a patient with a previous history of allergic reactions with low osmolar contrast media, then you better avoid giving these patients any more contrast. Is there a role of informed consent before you give IV contrast? I have seen almost all hospitals, diagnostic centers taking informed consent. I feel there is no need. And there is no need because there is a very, very low incidence of adverse events with the presently used contrast media. So, I think you should exempt the patient from the informed consent. I have found informed consent generally leads to more anxiety, and an anxious patient is more prone to adverse effects. Suppose I am going to tell the patient during the informed consent that, look, you might have a kidney shutdown, you might have an allergic crash, you might end up in a critical care ward of a hospital. The patient is going to be very, very anxious during the study. And that anxiety may precipitate more adverse events. Better avoid informed consent and make the procedure safe. I give a very, very big thumbs down to informed consent. Is there a role of pre-medication to reduce adverse effects? I've seen it practiced at multiple sites. You just give steroids and antihistaminics prior to giving IV contrast in the hope that adverse events and allergic like adverse events won't occur. Now, this is not of much use. Please don't do pre-medication. Also, there is a chance that a breakthrough allergic reaction may occur and very difficult to control. What about pre-testing? So what is pre-testing? You give a very tiny dose of intravenous contrast media and see if a reaction occurs or not. In 1991, a Japanese committee on the safety of contrast media said it is not useful in predicting severe reactions to non-ionic contrast media. So, pre-testing practically has no use. It is not predicting a severe reaction, and it itself can lead to a mild form of a reaction. I don't practice pre-testing at my center. I would also advise people not to practice big thumbs down to pre-testing. There is another important causative factor for allergic reaction. That is the rubber stopper of the bottle which contains IV contrast. Now, if I have seen it at multiple centers that people tend to poke the rubber stopper multiple times so that as to get a free flow of contrast. And remember, all these substances which are present in the rubber stopper might get eluted from the rubber stopper into the contrast media solution, and that itself can lead to allergic reactions. Please pierce the rubber stopper only once. Now, what are the things which we are going to be very, very careful about before we give IV contrast? Okay. See, all this carelessness will cost life. Carelessness, how do we avoid the carelessness? What careful precautions are we going to do? What care are we going to do? First is wash your hands. I don't know of many centers who would want their technical staff to wash their hands with soap and water thoroughly before they administer contrast. Also, make it a habit to read the label. Most mishaps which have occurred is because you have given a wrong drug instead of contrast to the patient. Whatever adverse event has occurred is not because of contrast, because you gave the wrong drug. Read the label before you give it. Ensure that you are giving the right drug, the contrast. You can wipe the rubber stopper with an alcohol swab. Use a 16G needle to draw out contrast from the glass bottle. It is a very easy way to do it instead of using the 20G needle which commonly comes with a syringe. And then do not touch these parts of the syringe or the needle with your bare hands. Finally, if allergic reaction occurs, then you have an antihistaminic like diphenhydramine as your best friend. I strongly recommend that you give an antihistaminic even if the patient has a mild allergic reaction. It will prevent the mild allergic reaction from progressing further and worsening. Also, beware of the panic attack. Sometimes a patient coming out of the CT room suddenly collapses, and then you think it's an adverse event, you think it's an allergic reaction, and then you also start panicking. Remember to use a pulse oximeter. Have a pulse oximeter in your radiology center. Use it to ensure that the oxygen saturation is okay. Get a BP recording and see that the BP is okay. And that's it. Assure the patient a little bit, and then the panic attack goes off. So in the past and even presently, we are told to be very careful when we use IV contrast with metformin in patients of thyrotoxicosis, in sickle cell disease, and with myasthenia gravis. Now, all these associations are unproven, okay? So there is no proof that if you use IVCT contrast in any of these conditions, you will have an increased adverse event. So you can best ignore them, okay, and use contrast whenever you are indicated to do so. So what is a preparation strategy before you give or decide to give IV contrast? What is the choice of molecule that you will have? What is the choice of brand? What is the dose that you're going to give? And whether it is a hand bolus injection or whether you're going to use power injector. So these are the broad indications known to everybody. If you have a stroke, if you have a trauma head and chest, do a plain only study. If you have a trauma abdomen, try to use contrast. And tumor or tuberculoma anywhere in the body, you have to do a contrast study. So three most common isoosmolar / low osmolar contrast media are iohexol, iopamidol, and iodixanol. What choice are you going to make for your patients when you have a choice of these three molecules? So that's your chart. Iohexol is the most commonly and widely used low osmolar contrast media. Its ease of delivery, wide availability, and the cost effectiveness makes iohexol the most popular. But remember, iohexol is more nephrotoxic than iopamidol and iodixanol. Iopamidol has a nephrotoxicity comparable to iodixanol. Now, if I am not having the serum creatinine levels, or if I am suspecting a potential adverse event due to a poor renal kind of a situation, I would recommend iopamidol or iodixanol. Iopamidol is also coming in the concentration of 370, and therefore if I am using a hand bolus, especially for chest and abdomen, I would tend to use iopamidol much more over iohexol. Only problem with iopamidol is it's slightly viscous, and you have to be very careful when you are using a power injector. Iodixanol, surprise, surprise, has a nephrotoxicity which is equal to that of iopamidol. So most cardiologists tend to use iodixanol. Now remember this, even if it has a nephrotoxicity which is equal to that of iopamidol and significantly lesser than iohexol, the incidence of late allergic reactions makes it not a very suitable choice, especially in a diagnostic center. Also, it is more costly than iopamidol. What is the dose that I normally use? For CT head 30 ml, for CT chest 50 ml, CT abdomen 80 to 100 ml, and 1 ml per kg is enough, and for CT angios 100 to 120 ml. Now these are not something which are engraved on stone. You can modify the dose depending on the weight of the patient, on the clinical story. Also remember, don't give more than 100 to 120 ml if you can prevent it. Let us discuss the role of power injectors. Now, I consider power injectors as the AK-47 of radiology. Power injectors are going to be very useful in the right hand and in the right clinical context. But here, our trend is to use power injectors everywhere. And thus, a power injector is like an AK-47 in the hands of a terrorist, causing untold mayhem and harm. So what is an advantage of power injectors? Power injectors produce good opacification in CT abdomen. It's absolutely vital for CT angiography study. But the disadvantage is there is a risk of extravasation, as we have discussed, We have seen patients panic because there's nobody there when an injection is going on. It's a costly thing. And also the syringe and tubings which are used along with the pressure injector are disposables. They are supposed to be discarded after every use. Now, this is a problem because nobody tends to dispose of these things and multi-use it in different patients over many days. Also, even if you do some sort of a sterilization, it may not be effective. Remember, any syringe or any tubing should be discarded after the patient is over. Throw it in the dustbin. So basically, when you use a pressure injector, you will get these phases. So you have a non-contrast phase, obviously. Then you have an arterial phase, a portal venous phase, and the nephrographic or delayed phase. Now, this makes sense in the proper clinical context, but not all patients require all these phases. Try to minimize pressure injectors wherever there is a clinical need to do so. Don't use pressure injectors in each and every case. Use of hand bolus injections are equally effective. Also remember, these syringes, these tubings with the pressure injector should be thrown in the dustbin. Don't try to reuse it on the next patient. Look at this pressure injector with a syringe on top. Okay. Now this is a patient has got over. Now they're waiting for the next patient. Meanwhile, there will be slight contrast within the pressure injector and it's going to be pyrogenic reaction for the patient, the next patient who comes. So we have another molecule, iopramide, not very common in our area, but it has got an adverse effect similar to other LOCMs, and with ease of delivery and good opacification, it is a choice at a lot of centers. What do you do if the patient is breastfeeding? Remember, in a breastfeeding female, if you give a IV contrast, then it's safe for the infant. The amount of contrast which is going to reach the infant is very minimal. It's not going to have any sort of adverse event on the infant. In pregnancy, obviously, why will you do a CT scan in pregnancy? There are a lot of other imaging alternatives available. Unless absolutely necessary, we won't do a CT scan. And furthermore, we don't know what is the effect of contrast when we use it during pregnancy, so best avoid it. In children, see, if you have a viscous and a low osmolar contrast media, then you can have issues. So iodixonol is better is only in the adults. In children, iohexol would be a better choice. Iohexol is less viscous than iodixonol, so better delivery. Use iohexol in children, not iodixonol. Remember, iodixonol is better in adults, not in children. See this beautiful picture, renal angiography. This renal angiography has been done on an MRI. Also, it is non-contrast. So this is the imaging alternatives which I have talked about earlier. In case you have an imaging alternative like a non-contrast renal MR angiography, use that. Na? Why are you bent upon doing a CT angiography here? This is the MR non-contrast angiogram of the lower limb arterial circulation. Quite a decent choice for your routine evaluation. Use this as the first step. if it is available.
So what is the most important take home message is do not multidose and discard old disposables. Do not reuse. If you have any questions and queries, contact me on 937 310 8337.